Good afternoon, everybody, all those who have arrived. Welcome to the second webinar of the joint action on addressing chronic diseases and healthy aging across the life cycle. Today we will discuss health promotion and chronic disease prevention and what the joint action has done in this field. We are again the same moderators as last week, for those who were there last week. So we are here, Anna Gallinat and Anne Pearson. Let me start by giving you a few information about how the webinar will be run. You can ask questions from the chat panel that you have on the right-hand side of your screen. You have a chat. So when the presenter presents his slides, you can type questions during that time, and we will come to the questions after the presentation. You will be muted during the whole presentation so that we don't hear unnecessary noises like doors that slam or whatever. Yes, I think what I have to tell as well is that this meeting is recorded. So if you don't want to be recorded, you should then mute yourself all the time. Then, as I said, we will have the presentation, and after the presentation, you can put questions, and we will also have an evaluation questionnaire that will be sent after the webinar. So that we ask you, if you could, please fill in, because that's very helpful for us to improve our webinars. Some information also for social media, for those of you who follow and who like to interact on social media. You can follow us at EU_CHRODIS and use the hashtag chronic diseases to follow us. And then at this point, I want to introduce our featured speaker for today so that we can proceed with the webinar itself and with the content itself. Our guest is Alexander Haarmann, who is Scientific Officer at the German Federal Center for Health Education, based in Bonn. As Carlos Segovia explained last week, this joint action focused on three main topics. On health promotion and disease prevention, that was one topic. The management of patients with more than one chronic diseases, that's the second. And then we took diabetes as a case study, that's the third one. Today, Alexander is going to tell us what the joint action has achieved in terms of health promotion and disease prevention. He will tell us about the work and about the outcomes. So Alexander, this is now over to you. Welcome to the webinar, to the meeting.
Alexander, can you hear us?
Hello, does that work now?
Yeah, we hear you now.
That's working, yes.
Okay, that's good. So yeah, first of all, thank you very much, Anne and Anna, and thank you for joining us. I mean, scrolling through the list of participants, I see quite a number of well-known names and a couple of others. Yes, as Anne already pointed out, I'm going to tell you a little bit about what we did over the last almost 3 years by now. And for those who didn't join last week's webinar, as you know, this is a series of webinars. I thought to just give a short wrap-up of what this whole joint action is all about. So the underlying observation is basically that NCD's non-chronic diseases affect 8 out of 10 Europeans in the age span 65 years and older, and that according to estimates, some 70 to 80% of the healthcare budget across the European Union are spent for their treatment or the management of chronic diseases. So of course each country could try to tackle these problems on their own, but joining forces makes much more sense as this is a common European problem. So this is what basically some 71 associated and collaborating partners from 26 member states and collaborating countries like Norway or Iceland have done, and we have joined in the joint action on chronic diseases and promoting healthy aging across the life cycle. So this is what we've done, and as Anne mentioned, so far there are basically 3 topical work packages next to on dissemination results, evaluating our results and coordinating the different topics. But the topical work is basically subdivided into 3 work packages, and as Anne already pointed out, the main distinction between our work package, our group on chronic disease prevention and health promotion, and the one, for example, on diabetes as a case study, is that we are dealing about primary prevention, while the diabetes working group is rather focusing on secondary and tertiary prevention. So, having said that, yeah.
Can I just interrupt for a second? I'm sorry about that, but could you maybe also put your screen on so that we can see you at the same time?
Your camera.
Your camera, sorry.
I tried, so I got the request to turn that on already, and apparently it's showing that it's running, and I agreed to the request, but apparently it's not working so far.
Oh, okay. Well, no worries. Let's just go on then. It's pretty much.
So it's switched on. Webcam is not available, it says.
Okay. Well, let's go on. Sorry.
Let's see whether I can fix that, but
yeah, don't worry too much.
Okay, maybe it'll fix it over time. I don't know. So basically, I got the request and accepted.
Okay, no worries.
Okay. Yeah. To start with, I thought I would like to highlight 3 underlying assumptions or points that seem relevant to me for the work of our work package. One is that given the epidemiological transition, a lot has been changed from treating acute illnesses to managing chronic diseases. But on the other hand, that this also entails quite a huge portion of lifestyle-related effects and factors that count in. So, in conclusion, chronic diseases can often be prevented, or at least delay their onset. So this is one point. Another one is that, as already mentioned, of course, each and every country could try to tackle the problem of the burden of chronic diseases on their own, while the sheer lack of information prevents or has so far prevented an exchange of experience, of knowledge and experience across borders. But looking at what good practices and programs are out there, there's a huge wealth of different programs, practices, strategies in Europe, so we should try to make that available to everyone and in a sense also share the knowledge that is gained. And then I think it's important to highlight that the approach we've chosen is not a means in its own end. It's not something we would like to deal with, or that is somehow conflicting or somehow not, separate from what the individual national activities are. But that we do is complementary and in line with the national activities that are done in the various member states on chronic diseases. So having said that, I thought to outline what process this work package, this group underwent, because these are more or less 4 different steps that are building upon each other. So the first step was to identify gaps and needs, but also good policies in the various countries. And what we came up with was a list of 14 different country reports that highlight exactly those topics. And in addition to that, we taking out the main results from these 14 country reports, a summarizing report is written highlighting commonalities but also differences. So this is available online for everyone who's interested. I will present the internet address to that later on. A second step was then to define what we actually mean by good practices, because as you might have noticed, quite often the talk went about best practices over a long period of time, and we diverted from that road by saying, okay, best practice, that somehow implies that you can't improve this practice, but it also means that it is best no matter the circumstances and the structure it is embedded in. And by renaming or rephrasing that a good practice, we would like to highlight that even a good practice can benefit from other experience, and that it is good from the perspective of the one implementing it, but also looking at it from an interested point of view from the outside. So what we basically did here was to ask our partners to collect information on practices that they believe are good and well and beneficial to health promotion and disease prevention. What we also did is a literature research on other good practices, so that we got a quite good and comprehensive overview of what is out there in Europe. And as a last step, we formed a 3 steps Delphi panel on health promotion, where experts had 3 rounds of discussion, and this resulted in, there we are, 10 different criteria that are comprised of 28 different categories. And the advantage of this approach is that it results in weighted overall scores, so that in the end you can compare practices with each other. But on the other hand, this also implies that if, for example, raising your sustainability in a program that, I don't know, specifically is targeted to ethical considerations, then you can single that out and sort these programs and practices that you're interested in, see what is interesting for you. This has to be advantage to someone that is seeking to improve his or her own practice. And then again, the collection process started. We have collected already, assessed by the criteria I just mentioned. So this whole endeavour resulted in the collection of 41 good practice examples across the life cycle. And a huge range of different settings, age groups, socioeconomic groups, different policies, health strategies, so that basically no matter where you are, no matter what you're interested in, there should be some example for you out there that might interest you, and that basically you can learn from and participate in the experience. Different sources that you could draw upon, and the most rich of them is a report with a very dense and very extensive description, ranging from, I mean, depending on what practice it is, between 2 to 18 pages. So, I mean, following a structured questionnaire. So, in the end, you get a pretty good image of what this practice is about and what they did.
So, sorry,
Yeah.
can everybody mute their microphone? I think we can unmute. We can mute everybody here, but it seems that someone somehow is calling from outside through the phone and is making quite some noises.
I think I am the problem. Sorry about that. Because I'm Francisco from Andalusia, and the thing is that we had technical problems to connect with the computer, so I use the telephone. The computer assistance is they're working on it, but for the being of not interrupting, I'm going to disconnect my telephone. Sorry about that. Good luck for the rest of your presentation, Alexander.
Oh, that's a pity.
Yeah.
It should. That was too.
That was quick now.
Okay.
Okay. Well. Yeah. Well, Alexander, go ahead.
Okay.
I'm sorry for coming.
I'm sorry about that. He left. Yeah, I think that's it about the collection. Yeah, I will show you the internet address where you can find the link where you can find the report later on. So basically, what we have covered so far, the first 3 steps in this 4-step approach, which are necessary to arrive at the last stage, because the overall aim for our web package is to come up with a recommendation report on transferability criteria. And this not only means, okay, we are satisfied with a collection of good practices, but what we also undertook is to analyze how these good practices possibly can be transferred, and what factors play in for good and for worse. So in order to arrive there, we selected 6 different study visits with different good practices, and they were chosen according to, I mean, on the first hand, interest of partners that were interested in the practice themselves and interested in implementing them in their own country. But we also tried to, at a more theoretical level, cover a broader range of the different quality criteria I mentioned early on, and different age groups, things like that. So I thought to go into that a little bit more, to give you somewhat of an idea of what the range was all about, but also of what we did, what kind of projects we were dealing with. So the first study visit went to a project in the Netherlands, Young People at a Healthy Weight, JA-CHRODIS, which started out in the municipality, but has now a centralized concept. I think 80 different municipalities joining and is implemented locally, with a target group ranging between birth age to age 19. The main measures here are primarily health education, sports education, healthy foods in schools and their canteens, and this is achieved with public-private partnerships, with collaboration with sports club, but also targeting employers to do a little bit more about the young adults and have an eye on them, and looking at the evaluation results. This program has been ongoing for only a couple of years so far, so that there might be more to achieve, but the first results sound really promising, with a considerable number of young people lowering their weight, and of course being more aware of what they eat, what they do, things like that. The second was a study visit where an exchange of interested partners was going on about how to set up, how to plan, organize and maintain databases, because there's quite a number of countries out there that already maintain a database on health promotion, but there are others that are still trying to implement one of them. So next to having built up a known database in this project, this was about how to best do that. The third study visit was off to Lisbon in Portugal, and we were looking at the National Programme on Healthy Eating, which is a national program with a collaboration at the regional and local level, and it is basically implemented locally. The target group differs from first, and it's basically all kinds of inhabitants, no matter what age, living in deprived areas. Here the main measures were health education in schools, in public spaces, sports courses in public spaces, but also at school, raising awareness of what is healthy to eat, what physical activity can promote, celebrating festivals where health-related topics play in. It was about healthier food in schools, exchanging water instead of drinking soda, and a number of different actions, be it in schools, be it in canteens, be it in hospitals, to decrease salt and sugar levels. And that also continued at national level, where, for example, this resulted in a smaller packaging of sugar sachets in cafes and restaurants, for example. And overall, this whole approach was possible through a intersectoral collaboration between different departments, but also different entities, and in the end, of course, a public-private partnership, which is an interesting thing, which is highly debated in many countries. But here it has led to the collaboration between the ministry and, for example, the 5 largest supermarket chains in Portugal, where the knowledge and experience about nutrition from the ministry is exchanged towards the promotion of healthier food, but also to the benefit of being recognized as a supermarket that is active in this area. The fourth study visit was subdivided into 2 smaller topics. The one, I went to Iceland. The first one is on the National Curriculum Guides on Health and Well-being, which is a national approach. So far, these guides, this curriculum, included 5 different pillars that needed to be highlighted and taught, brought across no matter what subject it was mentioned in. And like, for example, equity, the equity of all individuals. And to these 5 pillars, a 6th one was added, and this includes, for example, health and well-being. Targeted are preschool children and pupils, so the age range between 2 and 19 years of age is reached, and this is done in an intersectoral collaboration between different departments, different ministries, and of course entities. The Welfare Watch was and still is a program that is designed to measure and assess the effects that the financial crisis has on families in Iceland. And in order to prevent that this stays unmonitored and in order to also lay the basis for further political decisions. So this is a study on the one hand, but also bring up a very good basis for political decision making. The fifth study visit went to the Lombardy region and took a closer look at workplace health promotion network there. It's a regional program in collaboration between the public sector, but also a private network of enterprises, which is still growing. The target group is throughout the workforce, no matter what age group, what background or branch they are in. And what actually is done is very much dependent on the branch and the enterprises themselves. So the program might look like very differently from one place to another, but there are key areas of work they are targeting, which include nutrition values, tobacco use, physical activity, increasing physical activity, but also a topic like road safety, which is quite often not included in other programs, but also things like alcohol abuse. And the interesting thing in comparison to many other programs is not only that this is done in collaboration with the local associations, but also that it's not purely on workplace health, but goes much more beyond the workplace. This is, so to speak, the entry that has been chosen, but it is much more about general primary prevention than workplace health in itself. And finally, the sixth and last study visit went to London, to a program called Well London, and is now renamed to Well Communities, which is in its origins a local program that targets all kinds of inhabitants in deprived areas. Starting out from one borough, this program has so far reached more than 40 different boroughs in the area. And what made it even more interesting is that the usual recipes how to tackle this issue of chronic diseases, like health education, raising awareness, raising health literacy, raising level of physical activity, didn't work out because people didn't attend these courses, people weren't interested. So they changed the whole concept and tried to listen to what the inhabitants on site actually wanted to do. So once again, what actually is done in the various boroughs differs to quite some extent, even though there's some central coordination, but there are workshops and courses, community going on in one place that are not of that much interest in others, while other things are done here and there. So it differs. There's a common and centralized concept underlying, and it's very much demand tailored to what these inhabitants would like to see and what they think they can benefit from. And the first results of the ongoing evaluation shows quite promising results here. Not only that the well-being in the different boroughs has risen, but also that apparently through this community work and community building process, health levels have gone up. Another interesting thing here is that starting from this experience in London itself, the intention is to scale up this program to other areas that are similar, be it other rural, other cities in the UK, but also some of the more rural areas. So, having conducted this exercise, we're not done with the final analysis, but we still try to find out, of course, a number of commonalities between these study visits in order to find out, I mean, all along this question, what factors can be identified that benefit the implementation, what helps to transfer and adapt it. And as a first result, this we have arrived here with these 4 different headlines. So one of them is which is running through all kinds of projects and has shown to be very important for access, an intersectoral, multi-level approach with a high commitment, not only at the lower levels but also support from the higher ranks. This needs to be ensured in order to make projects and practices viable. Another thing is that it doesn't help to come up with very nice and thought through practices if they are not taken up, so at least some level of bottom-up approach should be included, that practices need to listen to what actually is needed on site, and in order to engage people, but also to make them motivated to join. A third point is that over and over again the importance of evaluation has been shown and highlighted. Quite often this isn't done properly due to lack of funding, but this doesn't make it less important. Another thing that often is not highlighted that much is that even throughout the process of implementation, a tight monitoring process should take place in order to see what factors are actually working out and which do not, and even this monitoring and documentation about the factors and variables that don't work is quite important in order to see the interdependency between the circumstances, between the environment, things like that, and also draw the lessons from these process when transferring it and adapting it to other circumstances and preconditions in other areas. And lastly, the longer term perspective is quite important for many programs, because usually programs last for, I don't know, 2 to 5 years, but given that perspective, usually most people involved in it tend to lose motivation after 2/3 of this time period. So giving programs, giving practices a long-term or at least longer-term perspective in order to give them a chance to mature and stabilize themselves is quite important, as we have found. These 4 short points will be dealt with in depth and explained in our final report with a further recommendation of what things should be taken into account when planning to adapt and transfer a given practice. So, and then, come on, this is basically the list of different reports and results that are mentioned, that I mentioned before, and which are then gathered in these reports. So this is basically what I thought of bringing across so far, and yeah, looking forward to an interesting discussion.
Okay, thank you very much, Alexander, for this overview. We are now going into the questions. We haven't received any questions during your presentation, but do people have questions now? We are unmuting you all, and please, if you have a question, just go ahead. Hold on a second, because we're not. Ah, yes, it seems.
Yep.
Okay, there is a question here. Alexander, I don't know if you see it as well, but I imagine, from Alison Turner, I imagine there isn't yet evidence of impact on chronic diseases from the project studied.
This varies quite a lot, and I mean, on several dimensions. I mean, there isn't evidence for quite a number of these projects. On one hand, because they haven't planned to do this. There's only a small number where this applies to. There's another range where evaluation is still going on, because many of these practices have started only a couple of years ago or only a few months ago. So not all of them have undergone proper evaluation so far. And then there is the aspect of different quality levels of evaluation. I mean, some of them only set up some criteria that they found to be very important, while others have come up with very complex evaluation schemes. So this varies throughout these 41 different practices quite a lot. But when it comes to the study visits we conducted, quite a number of them have very promising first results, and the final report on the evaluation is expected to be published rather soon. I mean, basically in the next year to come.
Are there more questions? I had a comment, in fact, that it's interesting to see that everywhere you speak about bottom-up approach, because that was also the case even for employees, for example, in the case of Milan, where you could think it might be different in different settings, but there as well, that was one of the first thing they were saying, is that they were listening to what the employees wanted, and they would first ask what employees would like to do before implementing any good practice there too. Will you be making recommendations for improving, standardizing evaluation methods and techniques, e.g. a gold standard or set of standards throughout Europe?
I think that this is basically not at the core of our recommendations. We thought much more in line of the ones that I've mentioned so far. I mean, above, let's see, where's that one? There we go. But as it is shown here, I mean, as evaluation apparently cannot be viewed separately from the good practice itself, but is part of it, and I mean, adds so much to the acceptance of a project, because as we heard right now, the usual question, the usual first question is, what about evaluation results? Is this efficient? Can we rely on that, or is it just a gut feeling? As it is so much interwoven into the success of these different practices, there will definitely be some points on that as well.
Are there any other questions? I think you can also talk, I mean, you can talk through, in principle, through the webinar. Well, Alexander, what are the good practices that Germany would be interested in implementing? Well, that's for the future, but that Germany might be interested in the future.
I think that there's quite a number of interesting good practices out there. With our ministry, or at least the department responsible for being part of the joint action JA-CHRODIS, is very much interested in is healthy aging. So, of course, quite a number of projects come to my mind. When, for example, there's one going on in the northern part of the Netherlands, in Groningen. Which is a very complex project to socially embed the elderly, but also raise health levels, making them more physically active. Everything that is targeted within the younger age range is here done as well, in addition to things that specifically are targeted to the elderly population. This might be one thing. I know that in the Basque country there's a similar program going on as we are developing here, making elderly more physically active and trying to raise the awareness that even the older population can do something to increase or at least maintain a certain level of quality of life, and that starting prevention is not too late. That there's never a point in life where preventing things can be regarded to be too late, and this perspective has changed over the last, I don't know, maybe 10-15 years, because previously quite often the assumption was that there cannot be done anything anyway any longer, and I think that has changed, and this is something that in particular we would be interested in to take a closer look at.
Thank you.
But as you have seen probably, I mean, this was just a very small range of examples. No matter what you are interested in, and no matter what your regional, national, local, whatever focus is, there's a huge range of different programs and good practices collected. And I would guess that this is a comparatively small share, given the even larger number of good practices that are still unnoticed going on out there in Europe. So I think it would be a good idea to continue this approach and collect and very densely and very extensively describe these practices in order to get an idea what this is all about, but also to take then contact with the practice owners and make it more well known in Europe.
Okay, we have another question. If you could please comment on the outcomes of step 2, defining good practice criteria.
Come along there. Is there anything you're specifically interested in, or would you like to hear a rather overall general comment on the outcome?
I don't know, this comes from Alison, but it helps to see the slide again. I'm not sure why she cannot, in fact,
She muted herself.
she muted herself. Okay.
Okay. Is it that one or the previous one? Yeah.
This one. This one.
I mean, there's also a report on that, so going into the details, different criteria mean and what the underlying 28 other categories that these 10 criteria are made up of are all about. So maybe that would be an idea to go to that report and take a closer look.
Alexander, in the I'm really interested in the evaluation element.
Yeah, I think this is, I mean, as it is designed right now, you're very relying on the accurate description of the project by the practice owners and how they have planned, organized, and conducted the evaluation part. So this might be something that you might want to check and might be improved over time. But there's a section on all of the collected good practices, what kind of evaluation has been done and what the dimensions that were evaluated are. So you get a more or less clear idea of what the evaluation part in the various and respective good practices actually were. And then, of course, quite some time has passed since then, since the report has been written, so there's always the address and contacts given, so that you might want to approach the practice owners and see whether there has been a follow-up or what the evaluation report now is done and what the results of them are.
Thank you, Alexander.
I think you wanted to pose a question.
Yes, but if we have other questions, empowerment and participation examples.
This touches basically the questions like how to involve your target population and how to make them not only passive participants but also actively take part, but also take something from it in order to learn for their everyday practice, their everyday life. So to make it more sustainable even after a certain program, a certain course, whatever, ends. And this has been also part of this structured questionnaire that everyone needed to answer in order to describe their practice, which then was assessed. So you will find a section on that in the description of these practices as well, how this has been taken into account in these respective good practices. Sometimes it's only 1 or 2 sentences, but sometimes it's quite an elaborated approach how to involve them and how to make the most out of it for the participants.
Thank you. Yeah, I was wondering, in fact, if you know, for the good practice in Portugal, when you mentioned that they reduced salt in the within the measures, was that did they manage to have a policy on that, or was that just a measure that people agreed on, but without being something fixed in law or so?
Actually, the interesting thing, I skipped that because I didn't want to spend too much time on that, but actually it's quite an interesting thing as well. There has been a guideline already since, I don't know, 20 years maybe, of about salt levels in food as a recommendation and how much the intake for an adult and children should look like. However, quite often the main dish for lunch in Portugal seems to be a hearty soup, and of course, in order to make it more tasty, quite often the level of salt used to prepare, to cook the soup was way above what was recommended. But as it is such a widespread dish, it's raising some concern. So what the authority subordinated to the ministry did was to contact a university in these matters, and they developed a device which not requires a huge laboratory to test the salt level in these foods, but a small sample would suffice to make a test on the level of salt included in this specific food. And there's a growing range of food that can be analyzed, which then takes some, I don't know, 5 to 10 minutes depending on what kind of food you have. And over time, this device was developed, and now there shall be a small series of devices that are then provided to public kitchens, be it school canteens, be it hospital kitchens, things like that, in order to see on site, okay, you've reached the target, you have once again put more salt into the dishes that then it is recommended. To do it on site and to prove, okay, it's not about your taste, it's not about your gut feeling, I didn't put more into it, but it's actually an objective measure that is easy to apply and has reaches, I mean, has effects on quite a number of people, because it's basically targeting all public or all kitchens that are organized in the public. And later on, of course, you might think of developing or that tastes are accommodated to this low salt level, so that even in the long run, restaurants and cafes in smaller places will adapt their level of salt to that generally accustomed lower level.
Yeah, yeah. Okay, thank you. Is there one more last question, perhaps? If not, then I think that we can probably close the webinar here, because we are almost over the time anyway. So no more questions? Okay. Well, then thank you very much for joining us today on this webinar on health promotion and disease prevention. As I mentioned earlier, we will send an evaluation form, and we ask you to fill in the form so that we can improve ourselves. We will post the presentation on our website, so people can always come back to the presentation, and also the video itself will be on YouTube. Well, I remind you that next week, the same time, on Tuesday at 2 o'clock, we will have the next webinar, this time on multimorbidity, and we will send you the link on Monday, as we did for this one. And then I think, well, on behalf of the Joint Action, and on behalf of BZgA and EuroHealthNet, we thank you for attending, and thank you for your time, and we say goodbye.
Goodbye.
Bye-bye.
Thank you, goodbye.